And we'll start with a poll. So we'll just gain some information from you to start off with. And we'd like to know what brings you here today. Great, looks like we have a lot of people from community-based organizations, a number of community members. We have some mental health professionals, some folks from faith organizations, and some educators. So we have a good group of people today. Okay, we can go ahead and jump into the webinar.
Great. Thank you, Claire. And thank you all for being here with us. We're really excited to share with you some of the findings from the formative work that we've been doing to help shape basically the Harlem Strong intervention. This project is an NIH funded study and an RWJ funded study that is focused on system transformation to address health disparities. The title, oops, I think we've lost our slide. The title of our initiative is called Harlem Strong. It's a mental health and economic empowerment coalition, which is focused on creating a multi-sectoral community collaborative model for system transformation. And it is led by myself and Dr. Malcolm Punter from the Harlem Congregation for Community Improvement, Deborah Levine, who leads the Harlem Health Initiative at CUNY, and Dr. Susan Bean from Healthfirst. And with that, I can go on to the next slide to set the agenda for us. So we'll be going over several parts of the formative work that we've been engaged in. The first is the multi-stakeholder needs assessment, which I'll be sharing some of the key findings for, along with Claire Ogburn. Then that'll be followed by Community Stakeholder Planning Council findings, which is essentially a set of focus group discussions we had with different stakeholders to get feedback on different parts of our program. And then Andrea Lopez will be sharing about our resource mapping that covers the community-based organizations and the different types of services that they offer. And then we'll end with Rashi Kumar, who will be presenting on the Healthfirst claims data related to Harlem and mental health needs. Okay, so I'll start with the needs assessment and go on to the next slide, Claire. So the goal of this needs assessment, it was really to understand the mental health and social needs and resources in Harlem from the perspective of residents and community-based organizations. We wanted to quantify the prevalence of mental health risk and examine the relationship between mental health, COVID-19, and social risk, and then also identify barriers to care, as well as challenges in providing services during the COVID pandemic. And lastly, all of this was to inform the development of Harlem Strong. So we use multiple methods. We had an online survey that was distributed during the summer months of this year. And then we also collected that data from residents and community-based organizations. That was followed by key stakeholder interviews with residents / consumers, CBO staff and leaders, and faith leaders. In the resident survey, we collected data on several different outcomes. First is mental health. So we included screeners for depression, anxiety, PTSD, and interpersonal violence exposure, as well as alcohol misuse. We also collected data on employment insecurity, food insecurity, housing insecurity, history of discrimination, perception of police, along with some other social outcomes like social support and service preferences. And then we collected data on barriers to care. In terms of the CBO provider survey, We asked them questions about the characteristics of the community they served, about the impact of COVID-19 on services and on operations at the CBO, as well as mental health training needs and technology challenges, because many were transitioning to technology and remote services. And so we wanted to have a better understanding of how that was going for them. And now I'll go into some of the findings. And, first we'll talk about the characteristics of the residents that we collected data from. There were 393 that were included in the sample. That was made up of, on average, the participants were about 34 years old with a range of about 9. The majority were between the age of 30 to 39. In terms of gender, 54% was female. In terms of the race and ethnicity, 65% were non-white. That was made up of 48% African-American, about 10% Latino, 6% Asian, 35% white, and then 0.5% were of multiple ethnic groups. The majority were born out in the US, so we only had about 8% that was born outside of the US, 70% were married. And then in terms of education, 52% had college education. And then in terms of income, this sample, because we oversampled from folks in low income housing, we had a slightly lower, economic status group than your average in New York City. The majority had individual incomes of about 25 to 49%. And then in terms of family income, the majority had family incomes of about 50 to 100,000 or 99,000. In terms of the number that was in market rate housing, which includes those who own or rent with market rate, we had about 65%. And then 35% were those that were from affordable housing or NYCHA housing, which is public housing. Okay, next slide. So you can see here that the risk for mental health is really high. 66% had one of the 3 mental health risks that we identified. So 66%, that is about 3 times higher than what it generally is in the community. In terms of depression, 41% of the sample screened positive for depression, 48% screened positive for anxiety, and 26% screened positive for PTSD. These are all very, very high numbers. It really speaks to the state of crisis we're in terms of mental health. The needs are very high. Next slide, please. And then what we did was we wanted to understand the social risk. And so, here you can see that there's employment insecurity, housing insecurity, food insecurity, childcare challenges, interpersonal violence, alcohol misuse, and use of marijuana, as well as whether they were exposed to COVID-19 and social cohesion, trust in the community, as well as perception of police. And what the first column you see are the overall rates for the whole sample. After that, you see it broken down into those who are not at risk for mental health and then those who are at risk for mental health. And then the p-value represents when something is significantly different between the two. And so when you look at this, you can see that many of these variables are associated with mental health risk, with employment insecurity, housing insecurity, food insecurity, interpersonal violence, alcohol misuse, everyone using marijuana, cocaine, heroin, and crack, as well as COVID-19, social cohesion, and perception of police, all being associated with mental health risk. And so that really speaks to the interrelationship between these variables and the need to probably address them simultaneously. The next slide. Here we have service needs. And so this is from the consumer surveys. About 74% indicated that they wanted support for mental health care and counseling, housing, and food. and then 58% wanted support for other financial assistance, and then 45% for legal support. So over, half to the majority of the sample are asking for services related to these different areas. This is also very high and probably much higher than it was prior to COVID-19. Next slide. We also asked about barriers to services, and there were many barriers listed. The barriers that was highest included, not having transportation or having inadequate transportation, difficult to schedule appointments, mental health care costs too much, having difficulty getting time off of work or school for services. 86% indicated that they had some barrier, which included the list of the barriers here. We also see a difference between those who are in market rate housing and those in affordable housing. So the differences include barriers related to difficulty getting time off of work or school, and then also insurance, lack of trust in mental health providers, not feeling comfortable sharing about their personal life and emotions, don't want people to know that they see a mental health provider, and so these are the ones that are different between the two housing types. And this is really important because for Harlem Strong, we're very, interested in supporting those who are higher risk. And so that means supporting mental health integration in housing developments. And so we need to pay particular attention to these factors because this is where, there may be more challenges for those who are living in low-income housing. Next slide. Now we're going to switch over to the CBO. I'm so sorry about all the honking. So now we're going to switch over to the CBO surveys. We surveyed 28 CBOs, 38 providers, 17 were leaders, 21 were staff, 82% were female, and the majority, or 42%, were 40 to 59 years old, 42%, 20 to 39. So basically the majority of our sample is from 20 to 59. On average, they had pretty significant amount of time at the CBO, 8.7 years working at that CBO. We had different types of staff responding to the survey. I guess 26% were senior management, 26% project managers, 18% program or service staff, and then 30% were others. Most of them are Harlem based. Some of them serve the city. And then 5% were, organizations that were part of a national network. In terms of the zip codes, the majority were from 10027, 10029, and 10034. So I think that's like central Harlem primarily. Okay, in terms of some of the characteristics of the communities that they serve, most of them provide services in English and in Spanish. The services that were most common among the CBOs that we surveyed included community living support, residential services, personal care. And all of them said that they had services reduced during COVID-19. Many of the consumers that they serve, included African-American, Latinos, and whites. And they serve a broad range of consumers, including children, adolescents, students, parents. In terms of the impact on their services, 86% switched to remote during COVID-19, and then 86 and 81, so 86 for phone and then 81 for internet services. 73% indicated that they minimized the number of consumers that came to the office, and 65% increased communication with their boards, employees, volunteers during this time, and probably because it was easier to communicate through the internet or on their websites and newsletters and emails. We also asked them about mental health services and mental health needs. 79% actually indicated that they had mental health training. And they also said that there was a need for more mental health services within the community. 95% of the respondents said that they supported consumers through referral and linking clients and consumers to mental health services. 29% actually provided some sort of mental health or emotional support program at the CBO. So that's a really good sign that there are some services already integrated into CBOs. And 42% said that they felt that there was adequate services for counseling at the CBOs. In terms of barriers for CBOs, many of them indicated a need for more training and digital skills for their community members. They also said that there are challenges in terms of hardware, so not having adequate computers and needing more IT support and maintenance at the CBOs to support the remote services and the use of technology. And 55% also said that there were challenges in terms of internet access for the consumers. So while many of them switched over to remote services, they also encountered a lot of barriers for the consumers in receiving those services. There was also a lot of interest in getting additional technology support. 71, wanted more tools and resources. 63% wanted more software technology support. 63%, was interested in learning more about how that can facilitate social and healthcare services, and over half wanted more training and technical assistance to support that. So, basically all of this comes down to us finding that there was a really high need for mental health, for mental health services. We had very high rates of depression, anxiety, PTSD, and exposure to interpersonal violence, all of which we know, has been extremely high across the country. But I think in Harlem in particular, it's very high, 66%, is 3 times the rate that it was prior to that. And in many other studies, they're finding it to be about 2 to 3 times, with 3 on the high end. So we are definitely on the high end in terms of need. We're also seeing that the factors associated with mental health problems include having, living in a low income housing development, food insecurity, exposure to interpersonal violence, COVID-19 infection in the household, history of discrimination, and also lower satisfaction with the police. All of this suggests that we need to be addressing some of these social risk and social factors along with mental health, because they are associated with mental health, and that the pandemic response, really needs to include, more attention to mental health services and social services, particularly for those who reside in low-income housing. And now I'm going to switch it over to Claire, who's going to share about the qualitative findings from our interviews with the stakeholders.
Hi, folks. So over the past year, the Harlem Strong team, residents of Harlem that lived in community wards 9, 10, and we interviewed leaders and staff of community-based and faith-based organizations that serve Harlem. We did, so we aimed to have more interviews, but as you know, most of you know, it's a lot of strain right now, and people's time is very limited. So you can see the number of interviews gathered here. So when we were talking to Harlem residents, we really wanted to know how the pandemic had impacted their lives as far as their jobs, their families. We were also interested in any kind of support during the pandemic from the government or other sort of benefits. And the major portion of our resident interviews were about mental health. So we wanted to know about residents' perceptions of mental health, stigma or lack thereof they may feel about mental health, whether they had access mental health services or would in the future. And then for community-based and faith-based organizations, we asked a lot of questions about their consumers that were similar, or their worshipers. So questions about how the pandemic impacted the people they serve, as well as themselves and their staff and others in their organization. And then we asked some about what kind of mental health interventions they think would be useful for the people they work with. So we can go to the next slide. So from the resident interviews, we went through all of the transcripts and sort of took out the big themes that we found across residents. So some of these themes are listed here. They include mental health stigma. So I think, we know that people are maybe reluctant to talk about mental health or to seek mental health services. There also is a lack of information available about what sort of resources exist in the community, whether for mental health or other benefits. We also found that within Harlem, folks feel that there's a lack of adequate mental health care providers in the community. People often end up, if they do get mental health services, they have to leave their community, which is definitely a barrier to getting mental health care. And one that Harlem Strong is addressing directly. We also found that there was a lack of resources for mental health and substance use services additionally. Can we go back to the last slide? Yeah, thanks. So a lack of resources for substance use services as well. A lot of folks were impacted by the pandemic as far as isolation periods, living with the unknown, and their impacts on their families and loved ones. But I think all this is to say that this is a lot of focus on sort of the negative aspects, but we saw that there was very strong community resiliency within Harlem, and very, some social cohesion. So we point to that as something that will be, helpful for the intervention. And then at the bottom, you can see some quotes from people we interviewed. I'll just give you a moment to read those. Okay, we can go to the next slide. As far as the CBO interviews, the main barrier that we found, or the people spoke about over and over again, was the really high turnover rates for staff. There's a lot of burnout among staff, and a lot of people were handling family business as well as other, pressures of life. So a lot of turnover in CBOs. CBO staff also noted the lack of adequate mental health care providers available in the community. And that partially could be due to the lack of funding to adequately pay mental health providers. CBO staff pointed to some aspects that they feel their organization needs to better serve the mental health of the Harlem community. Some of those were increased funding to provide more specific services. And we also saw an increased need for services to help the community meet basic needs. And then finally, some of the successes that CBOs found during the last year is that using sort of unconventional messengers to relay health messages was a strategy that worked well as far as health promotion, and one that this is a strategy that Harlem Strong leans on as well. And again, there's some quotes at the bottom. I'll give you a moment to read. They point to, the increase in people seeking services during the pandemic, and some needs for staff training. So we can go to the next slide. So I'm going to turn it over to Marina Weiss, who will speak about the Consumer Stakeholder Planning Council.
Thanks so much, Claire. So we'll be talking a little bit about what we found in the Community Stakeholder Planning Council meetings. Those were held with our community in order to better understand the issues that they saw as potentially arising from our Harlem Strong model, and to think together about how we could best serve the community with the intervention that we're designing. We asked community members about the obstacles that they saw to succeeding in providing community-based mental health support, and that included stigma of mental illness, which has three main components from the perspective of our community. They talked about how, compared to a physical illness, it was easier to support somebody who had a physical illness than a mental illness. So you can take a look here. This is a poll that we did during one of our discussions. Nobody strongly disagreed with this idea, and the majority of our respondents either strongly agreed or agreed with the idea that it would be easier to support someone with a physical illness than a mental illness. This is something we wanted to address in our program, and to specifically talk about the ways in which mental illness does have a physical basis, so that we can include elements like that in our psychoeducation around mental health as part of the Harlem Strong intervention. Next slide, please. So we also asked about how community members were seen when they learned that someone else had a mental illness, and whether people felt they were seen as weak or less capable. Again, the majority of respondents agreed with that. However, we noticed that nobody strongly disagreed or strongly agreed, indicating that there was some agreement around this, but people didn't want to go out on a limb in terms of the extremity of their responses. So there's an understanding that, on the one hand, the stigma of mental illness really exists, and on the other hand, people want to acknowledge that it exists while also addressing it and not contributing to it themselves. Which is also something else that we hope to address in this Harlem Strong intervention. How can we increase dialogue around these kinds of ideas so that we can help to shape the ways that people feel comfortable asking for support? Next slide, please. So we also asked about whether there's a widespread belief in the community that people should be able to fix mental health problems themselves without going to therapy. And this was one where we really see a widespread of responses. Some people feel differently. Some people feel like that there actually is a precedent in the community or a mentality in the community about asking for support from therapists and other supporters. Other people strongly agreed with this statement or agreed with it. So we can see the community is pretty split in terms of what we were seeing there. And that's something that we'll try to address with the Harlem Strong intervention as well. We want to understand how we can support people in getting the tools that they might need to support themselves more if they don't feel comfortable going to therapy, and also the ways in which we can help folks who do need that support and do identify as benefiting from it to feel more comfortable seeking therapy, just like they might feel more comfortable going to the doctor or going to the dentist if they need additional support around that. Next slide, please. So additional things that came up, there's so many themes that came up in these really rich and vibrant discussions, which we had, recognizing cultural variation within the many communities that comprise Harlem, thinking about how we can support navigators who are providing services within the Harlem Strong model, and thinking about assessing for social factors that contribute to people's resilience and well-being, using technology to allow for on-the-go screening, and thinking about issues like crisis management and how we can incorporate that so that we can help community members feel safe. And next slide. We also talked a lot with the community about ways we can incentivize consumer engagement. So making folks in the community feel comfortable seeing Harlem Strong as a place to go for these kinds of resources, and offering them things that will make it more comfortable and more flexible, and make Harlem Strong feel like an attractive option, whether that's including food so that people can feel like they're being nourished by their interactions with Harlem Strong folks, or incorporating flyers and materials that they can use to get the word out, as well as using online methods to increase engagement. And also incentivizing and supporting navigators by using processes like certification and offering continuing education credits where possible, or offering weekly and consultation and support for navigators so that they feel supported. So we basically incorporated a lot of the needs and opportunities that were identified in these meetings across the different areas of this project, going from how we're going to engage the community and connect them to our services, and also thinking about the ways in which we can improve current systems for providing mental health to take into account the factors that the community told us were important, like thinking about using preventative methods and thinking about addressing problems before they really become a crisis, offering additional kinds of training and support, and encouraging lots of different kinds of networked referrals within our network so folks can get connected to services across a variety of issues, and also making sure that there's a practice of following up when referrals are made so that consumers who need support around multiple issues do get connected to those services. And if they haven't gotten connected, they have another opportunity to make that connection. Next slide, please. So we can also talk a little bit about implementation barriers. The primary one is that there wasn't a lot of folks who were trained in mental health care. And that's something that we are going to address with the Harlem Strong project, is that we're going to train folks to think about and talk about mental health with consumers, and also to provide short-term counseling and referrals so that we can make sure more folks get connected to those services who need it. Mental health stigma is a big category, which we've already mentioned. My colleague Claire already mentioned it, but it can include self-stigma, preventing oneself from getting care by thinking that you should be able to handle these concerns alone, as well as stigma on the level of discrimination against folks with mental illness, or lack of knowledge about how to support folks with mental health concerns, or fear. And we also know that implementation barriers include the limitations around services available to our community at this time. So this is a long list of the various reasons that services have been limited. But we know that Harlem Strong will be working to address all of these barriers. And it's a pretty exciting way to bring an innovative approach to hopefully help folks get better connected to these supports when they need them. Next slide, please. So we had some action ideas that came up in our discussions with the community, and they've been incorporated into different parts of the implementation plan. So that includes thinking about creating this coalition, which which Dr. No and others have been working to create, to establish a network of organizations that are working together to make these changes, and also increasing access to services through our MCC model of care. I'll let folks take a moment to look at this slide. And then we can go ahead, because I don't want to take up too much time with this. We can go ahead to the next slide. And also thinking about providing data exchange and sharing across organizations to facilitate those referrals and facilitate collaborative care for consumers who are probably getting services at multiple places. So thinking about how we can create a shared way of making sure that people are getting connected to the care that they need, and that we can all collaborate in their care. Next slide. And then also providing community and provider mental health trainings, creating a directory of referral resources, and thinking about communications and training on social determinants of health. So together, these factors really help to support the ways in which consumers can have their mental health addressed by our model. So now I'll pass it off to my colleague Andrea Lopez for resource mapping.
Awesome, thank you, Marina. So in the next couple of slides, I will briefly go over our resource mapping efforts. So we have compiled a list of community organizations, primary care sites, mental health sites, and faith-based organizations from our partners, and we have created an inventory of these organizations and classified them based on the services they provide and the audiences that they serve. Next slide, please. Thank you. So overall, we have 313 organizations, including 30 federally qualified health centers and community health centers throughout Harlem, Upper Manhattan, and the Bronx. We have 76 mental health provider organizations, 106 community-based organizations, and 101 houses of worship. And all of these organizations directly serve the Harlem community. Next slide, please. So when it comes to the community-based organizations, we have 106 organizations focused on a total of 14 sectors. And these sectors include neighborhood preservation, social services, community improvement and development, substance use disorder service provider, legal services provider, pantries, shelter or temporary housing, community services, education, healthcare and wellness, youth and family services, trust or foundations, mental health care provider, and disability services. So based on the list of organizations that we have identified that the sectors with the most representation are those organizations that provide either social services or services targeting youth and family audiences. Next slide, please. So we have also explored provider types and the role of community health workers in the provision of services. So based on our mapping efforts, we determined that 31% of the community-based organizations utilize community workers, peer workers, or paraprofessionals as their main providers. 7% of community-based organizations rely on community leaders as service providers. And then 33% of faith-based organizations have active health ministries that provide services. Next slide, thank you. And we also explore how mental health services are provided by these organizations. So 34% of community-based organizations in Harlem provide at least one type of mental health service or support as part of their regular programming. 16% of community-based organizations rely solely on community health workers for the provision of mental health services. And these services tend to be mostly outreach, community education, or referral to services provided by other organizations. We also saw that 13% of faith-based organizations provide at least one mental health related service, mainly in the form of referrals, outreach, or peer groups. And these services were also designed to assist with mainly general mental health, depression, anxiety, and child development. So I will pass it now to Rashi from Healthfirst, who will provide a presentation on their claims data.
Hi, good afternoon, everybody. Thank you so much for inviting Healthfirst to present. We're just really so lucky to be part of this project. So you can go to the next slide. So Healthfirst, as most of you probably know, is an insurance company serving downstate New York. We serve 1.8 million members, which is about 1 in 3 New Yorkers. So we serve a lot of people in the catchment area for this project. So for the purposes of this needs assessment, we looked at our members who had either Medicaid or Medicare insurance, were adults. They were either living in one of the target zip codes in Harlem, or they had a provider in Harlem. And these members also had a diagnosis of either depression or anxiety in the past 2 years. So we looked closely at these members to figure out what we can learn about how they access the healthcare system and what we know from their claims their needs might be. So next slide, please. So first, I'm going to tell you about these members and demographically what we know about them. So next slide. So about 70% of these members have Medicaid and 30% have Medicare. And there's 25,000 overall who either reside in Harlem or they see a PCP in Harlem, and they live with depression and anxiety. And you can see from this map on the left that people from all over the city who have depression and anxiety actually seek care in Harlem, which is really interesting because we have a hyper-local neighborhood view of the neighborhoods in New York, but in truth, people really travel for healthcare, and that's an important reality to grapple with. And most of the time, we see that our members are actually seeing community-based PCP, so some of the smaller offices, as opposed to the larger hospital-based practices. In terms of race, ethnicity, you can go back just for a second, thank you. There's a really wide spread. Our members don't always have to tell us what their race ethnicity is, but you'll see that there are lots of folks who don't tell us, they're unknown, and lots of folks who are Black, African American, or Hispanic, and Asian. So next slide, please. So these members who have depression and anxiety, they're predominantly, based on our claims data, they're usually English and Spanish speaking women. This is really interesting because it might not tell the whole truth of the situation. These diagnoses are from claims data, so we only know they occur because they're a transaction with the healthcare system. We could suppose that there are also a lot of men who don't get diagnosed because they're less likely to seek care. In terms of the age of these members, the mean age, average age is right around 49, 50. But there are lots of members at the younger end of the spectrum, around 20, and there are lots of members around 65 also. They're kind of two modes. So next slide, please. So these members who have depression and or anxiety, those are not their only conditions. We found it pretty shocking, actually, that 84% also have a diagnosis of hypertension. A lot of folks have hypertension and diabetes. In our male population, we actually found that they're more likely to have substance use disorder and alcohol diagnoses, as well as psychoses and renal disease. And in our female members, we saw more claims related to obesity, hypothyroidism, and anemia. Next slide, please. So next, we also looked at how our members actually access care. And Healthfirst is a provider-sponsored plan. So we want all of our members to select a primary care physician and or we can help assign them a primary care physician if needed. And as you know, these members have a lot of conditions in addition to anxiety and depression. So it's really important for them to have a primary care physician. So for 2021, we saw that 40% of these members saw their assigned PCP one or more times, which is awesome. About more than a third had an alternative PCP. So somebody they saw who wasn't their assigned primary care physician, and a solid 20%, which is 1 in 5 of them, had no PCP at all. Next slide, please. So we use this construct of seeing if somebody is aligned with their PCP, and we look at other outcomes associated with that. So generally, we're finding that members who are seeing their assigned PCP for some reason, they are less likely to need to use the ER. And for members who do need to use the ER, pain is actually the top reason that they end up going to the ER. You'll see at the top of the chart, you have back pain, you have abdominal pain, and pain in the throat and chest, which may be related to COVID. COVID, alcohol use, anxiety, and asthma, these are some of the other issues that round out the top 10 reasons people have to go to the ER. Next slide. So similarly to the last slide, we find that people who are well aligned with their assigned PCP For some reason, they're also less likely to need to be hospitalized, to be admitted to the hospital. When they are admitted, the top reasons are alcohol, substance use, and mental health related disorders. So these are most of the top 10, and then COVID, cardiovascular disease, including diabetes and obesity, are other reasons these members who have depression and anxiety need to use the hospital. Next slide, please. So next, I'm going to talk a little bit about quality measures. Quality measures are, they help us understand as a health plan if people are receiving recommended care, and we work with our providers closely to make sure that members, based on the types of conditions they have, are getting the right types of care. So these are how we're rated as a health plan, making sure that we provide our members access to the right kinds of care, given what they bring to the table. Next slide, please. So first, I'm going to look at our youngest members. So I know there's a lot of data, so you can just listen to me and not try to read the tiny print. But we find that most of our members, even if they're not going to an assigned PCP, they are getting some kind of outpatient care. And this could mean that they're actually seeing specialists in addition to primary care, which is good. So these members, remember, they have depression and or anxiety, and they really need help with this antidepressant medication management. So this is suboptimal. Only about 35% are receiving the recommended care. And then after a hospitalization for any kind of mental illness, most of these members get follow-up care, but that's not always true. If there's an ER visit related to mental illness, that follow-up care only happens about 50% of the time. So next slide, please. As we go up in the age bands, now we're looking at 25 to 45, these same trends really persist. Again, with the antidepressant medication management, still an opportunity, and also the follow-up after an ER visit for mental illness. Next slide, please. And as we get into middle age, these, we're seeing even more engagement in ambulatory care. But we're seeing the same issues with antidepressant medication management and the same issues with follow-up after ER visits. Next slide. And our oldest members, again, facing the same issues. So we can go to the next slide. So just to recap our key takeaways, 25,000 members in these zip codes or seeking care in these zip codes who had anxiety or depression. So huge need that's already identified. And based on the claims data, we see that women are more likely to seek care and receive a diagnosis for depression and anxiety. Only 40% of our members with these diagnoses are receiving care from their assigned PCP, which is associated with lower ER use and lower inpatient hospitalization use. There are some really big opportunities presented by this claims data also. The biggest opportunity, which of course Harlem Strong is aggressively addressing, is improving the detection and treatment of mental illness across the entire population. And it looks from our data that this is needed, especially in our male population. Second, there's a huge need to make sure people are getting follow-up care after an ED visit related to mental health, and that we're helping people with antidepressant medication management if they need it. So thank you. I'll turn it back to the hosts.
You're muted, Vicki.
Thanks, everybody. And thank you, Rashi, for that great presentation. And thanks to the rest of the presenters. I wanted to use the rest of this time to open it up for discussion, because I'm sure you all have questions about different aspects of the formative work that we've been engaged in. And so I want, to do that first and see, if anybody has any reflections, any, reactions, any questions about what has been presented. everyone's muted, so I don't know if anybody's speaking. But I actually have a question for you, Rashi. You know, I think the claims data is really interesting, and it was really great that you have such detailed information about 25 members of, who live in Harlem or are served in Harlem. I was wondering if there was a shift in the number of folks who were identified as depressed or anxious over those 2 years. Do you have a sense of that? I know you didn't present on
Yeah,
it, but I was just
we
wondering.
didn't present on that. Yeah, I would love to, as a part of this project, if we could track that over time, maybe we could even start before the pandemic. And then,
That would be really great to see what those trends look like. And then also look at ER hospitalizations, because I think that's one of the worst outcomes, right? And one of the things that we all often try to prevent with mental illness. So to see if that's correlated with ER visits, if those are also, if those who have depression, anxiety are at increased risk of being hospitalized versus the general population.
Okay, that's a great idea. Sorry, I don't have the exact answer to your question, but I think it's a great idea.
We have 2 questions. We have one from Madeline Stokely and then one from Charles Shorter.
Hi, thank you so much. I am a Harlem resident and also the president of the Mount Morris Park Community Improvement Association. And thank you so much for sharing this information. I find it very promising because surely we need so many services and coordination in the Harlem community. My question is about 2 questions real quick. One is the perception of substance abuse services. You probably have heard there's in this particular area that are very concerned about the oversaturation of substance abuse services in a small concentrated area here in Harlem, particularly 124th Street between 7th and Lenox. So I wanted to know, was that a perception or was that based upon actual data? And then my second question, just real, and I'll stop talking. Just the training that you're going to be doing, what's the timeline and engagement around the training that you'll be doing? Thank you.
Right. Thank you for both of those questions. Yeah, I know that there has been a lot of debate and discussion about the saturation of substance abuse services in Harlem. We didn't ask about that. We asked about their risk for alcohol and substance misuse. And so they were screener questions, and we did find a very high rate of misuse. So we do have, I believe it was 60-something% of the sample, screen positive for substance and alcohol or substance misuse, essentially, which is very high. So the need is there.
I would just add, I think, Ms. Stokely, what I hear you describing is also a question about environmental racism and the ways in which services might be clustered within communities of color, like Harlem. Is that part of the question?
Well, really, I mean, I listed it under the lack of resources in an earlier part of the presentation, and maybe I got it wrong, but under lack of resources was substance abuse services. So that's particularly what I was responding to, and maybe I misheard what that particular piece meant. But yes, part of what you're saying, for those of us who feel, yes, many of us feel that the issue of racism has created a lot, just about everything that we see happening in Harlem that is negative.
Yeah,
I think that's a really important point, and one for us to keep in mind with this project as well.
And then to answer your second question about training, the project is expected to launch in February of next year. We are finalizing the formative phase, which is, our planning phase of pulling together the trainings, the intervention materials, and then recruiting CBOs, primary care sites, and housing into our study. And so the trainings will be made available in February when we launch the study.
Thank you.
Thank you. Charles Shorter?
Hey folks, Charles Shorter, Ryan Center. How's everyone?
Hi, very good. Thank you for being here.
I have a few questions, but I'm going to piggyback on some things that Ms. Stokely asked about and was kind of brought to my attention. And actually, it was looking at the slide that listed the programs. And the two large buckets were social services and then youth and families. So my initial question before Ms. Stokely had brought this up was exactly what are those social service programs? I think we need to do a better job of identifying exactly what social services means in that bucket, as well as youth and family services. And then to piggyback on what Ms. Stokely is saying, because youth substance abuse was a very, very small pocket. And I think there may be some substance abuse programs in that social services bucket. So maybe do a deeper dive. And in that vein, as a senior African-American male, and my colleagues I know don't go to the doctor, and I work very closely with Healthfirst, and when they looked at their claims data, 74% of the women had identified through the claims data depression and anxiety. So I know men don't come. I know that as a community health center executive, but the claims data that we do have for that time period for men, is anybody trying to do a deeper dive on that claims data? I have a feeling that men are not necessarily asked the screening questions, the men that do show up have a kind of a feeling. So if there's a way to do a little more deeper dive on that claims data from Healthfirst, one of my partners that I absolutely adore, that would be great. Thank you.
Yeah, I love that idea. I'm really interested in comparing screening data that's collected through this study with the claims data to see, what the gap is, because the screening data should lend a lot more truth.
Thank you.
Yeah.
And thank you for your suggestions about breaking down the categories better, because it's actually quite challenging to do the resource mapping because people use different terminology or the same terminology, same labels for different services. So it is quite complicated, and Andrea can probably speak more to that since she was doing some of the coding.
Yeah, so I was actually trying to create the pivot table to give you more details. I'm happy to share that with you right after our call. Because within social services, we do have some organizations that would fall into some of the other buckets. But we usually use it to define general social services. So they usually provide like not only housing, but also housing, mental health, food pantries. So I can give you more of a robust, I guess, breakdown of what what will fall done under social services if you want.
Thanks, Andrea.
No problem.
And we have others.
Hello?
Hi.
Can you hear me?
Yes.
Oh, I'm sorry. I'm sorry. My screen is messed up. I'm sorry, everybody. Hi, how you doing? My name is Gordon Muhammad. I'm a homeless outreach worker. So I work, sometime I sign up to Harlem. But I just want to say I was listening to everything. Everything is actually real good. But I just want to say, my time up in Harlem, just doing the canvassing and everything and what everybody's looking for and want, I realized that the area of Harlem is it's similar to dealing with drug-induced psychosis up there. I really picked on it where, sometimes it's not a homeless issue, it's more of a harm reduction issue, where most of the methadone clinics and everything, they're not regulating what goes on with the clients inside and them leaving, and we're dealing with most of the local drug dealers and everything in the area. So sometimes it sometimes bring out the wrong stigma, but I truly feel like if we do more of the harm reduction approach, and maybe we might have to get PD, narcotics, and everybody involved and explain to them hey, what's going on, this is what we're doing, and just try to eliminate certain things that goes on in the area, because sometimes, if you walk some areas in 125th Street, down to First Avenue, you're walking into syringes, you walk into a lot of things, and I know what we're trying to do on the good Samaritan approach, but it's I just feel like it's not working at sometimes.
Thank you for those thoughts. I think, the there are many, many challenges
Right,
in Harlem, and
right.
we welcome your perspective, and we would love for all of you to join the coalition, because I think that's going to be the space where we're going to talk about what you all are seeing, from your, from whatever setting you work at, because I think having a much more nuanced understanding of how things intersect will really help us address the issue in a very local way. And that's kind of what we're hoping to achieve with this coalition, is that we have this local concentration of folks thinking about this together. So thank you for that. There's a lot of people with their hands raised, and I just want to make sure we get back to them. I think Teresa Manuel also. Oh,
yeah, we have Miss Vanessa Valdez and then Miss Manuel. Okay.
Hi, so I'm Vanessa Valdez. I'm the Associate Provost for Community Engagement at the City College of New York. So with that in mind, when I saw the Healthfirst data, I immediately thought about a couple of things. One, certainly, I work with a younger population than those who claim, who make the claims, i.e. I'm thinking of the women who are the average age, right, of those who are diagnosed, but thinking about primarily, again, the uninsured and how we are that outreach, thinking about what are the male spaces that we are reaching out to, right? Because again, even when we're talking about faith-based organizations, we know that, it just particularly as we go older, and we're looking at the demographics, I mean, even faith-based spaces, they tend to lean towards more populated by more women than men. And so just thinking about, again, other spaces of outreach in our areas is really key to me, because, we know, I think it doesn't surprise me when we see a correlation between hypertension and a diagnosis of anxiety and depression. And then just given the rates at which again, humans are, but particularly, peoples of color are diagnosed with hypertension. I'm thinking, again, that diagnosed with hypertension, how many of our neighbors are walking around not diagnosed, right, with those things. So I just wanted to say those things. And Dr. No, I look forward to seeing you tomorrow.
Yes, I love that too. And I just wanted to comment on what you were just saying about the uninsured. That's what the main reason why we're partnered with Healthfirst is, so that we can, increase access to insurance, because that is a big challenge. And we are so lucky that we're, working very closely, partnering with them. And, as we're doing the screening and we identify folks who need insurance, they will also be, connected to Healthfirst as well. I think, Claire, you want to go down our list of all the speakers or all the folks who want to ask questions?
We have Ms. Teresa Manuel next.
Hi, everyone. I'm off camera. Great presentation, by the way. Just one suggestion: when you guys spoke about the community-based programs, and you identified programs that provide disability services, I think that needs to be broken down, because disability can be viewed in several different ways, right? Because there are people with intellectual disabilities, right? So sometimes folks think that because they have they have difficulty ambulating, or they're in a wheelchair, or just different things. So that makes it more clear. And I am concerned that there's only one community-based program that provide disability services in Harlem, because I'm sure that there are lots more, in Harlem. So that's just one recommendation. And then the other thing is, and I think someone spoke about this earlier too, is a transparency in when we talk about the different groups that were surveyed, right? Because I think you mentioned that you surveyed non-whites and African Americans, right? So who are those non-white folks that were surveyed, right? Because I think that needs to have some kind of clarity there. And I can see how people can feel stigmatized in terms of, of course, we know the majority of the folks that probably live in Harlem are probably people of color, right? So, but that can be, also segmented in terms of, try to figure out, who are they? Are they Latinos? Are they African Americans? Are they, so I think that some clarity needs to be, be told there, so that way the story can be more clear to, to your audience, I think.
Yeah, I apologize for that. Actually, we do have the breakdown. It's African Americans are 48%, Latinos are 10%, Asian 6%, white 35%, and multiple is 0.5%.
Can you describe the boundaries? Because you know, Harlem is Central Harlem, it's East Harlem, it's West Harlem. So that's that 40-some% you mentioned. I'm not too clear on the boundaries.
Yeah, we have a list of the zip codes that were included. And so residents that reside within those zip codes were included in it. Let me see if I can find the zip codes that were listed. I don't know them off the top of my head, but we can definitely get that to you. And if anyone else on the team knows the zip codes that were included in that survey study, if they could just share it in the chat, that would be great, so everybody knows what's included. But it's essentially Community Board 9, 10, and 11. So all zip codes that were included. There we go. Claire's posted it. Thank you.
Next questioner.
Next, we have Mr. Richard Allman.
Thank you, and very much thanks for today's presentation. I'm with the A. Philip Randolph Senior Center on 146th Street, and I'll ask the simple question, is today's PowerPoint and related materials that describe the survey available to those of us who have participated today?
Yeah, I think that shouldn't be a problem for us. We can make that available. And the recording will also be available as well.
Should we ask you, or will you be sending that?
I think Claire or Priya will be sending that to all the participants. Usually there's a follow-up email that provides the link to the recording.
Great. Thank you so much.
You're welcome.
Now we have Miss Carolyn Johnson.
Good afternoon, everyone, and thank you for this continued interest in creating this project for Harlem. I'm the East Harlem Co-ed Community Organizations Active in Disasters. I think that oftentimes when initiatives are promoted, that it's wonderful, it has a lot of stuff involved, but when I look at the graph that was put up by Healthfirst, that's what you see now. That's what you see now, the numbers that you see now. Don't take a good look at what Ms. Stokely and the other gentleman was talking about is the oversaturation. There's going to be a creation of a whole lot more people with mental health issues that no one's looking at. Because you have children who will not go to school. They won't leave their homes because of what they're seeing, because of the addicts shooting up, sitting on the benches. The cops say they can't do anything about it. You have children that will only go out with their father. You have mothers that's afraid to go out or let their children come home again. They have to make arrangements to have a child who's been walking home all this time. You know, somebody else has to pick them up. The seniors are afraid to come out of the homes. There's a whole new generation of fear that is creating some serious mental health issues, and no one is going to take a look at that. So that is vital. That oversaturation is vital to this program. It's absolutely vital. And I don't know what we can do about it, but we've already sat in conferences with the police officers. They're saying their hands are tied. They can't touch people. They can't tell people to get off of their people's stoops. They can't run people off this. You know, I mean, that's all I'm hearing now is fear. It's a psychological and a mental warfare that's going on in our area. And no one is really looking at it.
I truly agree on that.
What do you think should be done? What do you think we can do together to address some of this?
Well, I think we got to be careful with like no one's doing something. I think the problem with us in Harlem is that someone said to me a long time ago that we're resource rich and coordination poor. We just got to find the folks who are actually doing this work. I know, for example, the 125th Street Business Improvement Association group, they meet every other week to go over these issues, and a lot of folks just don't know about it. So we probably need to look at the coordination aspect of this stuff and making sure that we're getting the right people inside the room.
That's great.
Well,
I mean, that's exactly what the coalition's purpose is to have the right people at the table so that we can share information, exchange, dialogue about these issues on a regular basis, and, sort out what we can do together.
And I think that's a major part in Harlem. We don't connect dots. People are doing everything all over the place, and they're not reaching out to other people. They know you exist, but we don't reach out. We want to keep our, whatever we're doing, we want to keep it to ourselves. And I don't know if it's the power play or what, but we don't reach out. We don't know if this man didn't say anything about the BID. And if I wasn't here in this meeting, I would never known that they were doing it. But we've been in this community, working in this community in emergency, for decades, back with the first heroin epidemic that we had back in the 70s. We've been doing this work. Why don't we know what other people are doing? And that's the thing. We have to get it out. And if you're going to meetings and these things are taking place, then we need to send it out, e-blast everybody at this meeting and other places so that we can all have information and connect with them.
Hello. Can you hear me?
Yes.
This is Ms. Chandler. I'm the TA president at Polo Grounds. I'm listening to Ms. Johnson, and I think that she is absolutely correct. Too many of us are not sharing resources because when something fantastic, fabulous happens, we don't want to share credit with anybody. We want to be the only one sitting at the head of the table, which is a disgrace. Because just like Ms. Johnson, I've got in my development, I've got people who are dual diagnosed. They have substance abuse and they have mental illness, and they are terrorizing my buildings. And I think that the people that should be sitting at the table are in fact the lawmakers. I'm sorry, and this is just the way that I feel. I think the mayor is exactly right to mandate that people be taken by force to the hospital. If they are not willing to get the help that they need, or they're not even in a position to understand that they are in crisis, somebody has got to be looking out for those of us who are not in crisis, but are held hostage by those who are. My seniors won't come out of the house after dark. Some of my young people come to me and tell me things. It's fantastic, the things that I'm being told that residents are suffering through. I think that it's a wonderful thing to take them to the hospital, whether they want to go there or not, because the rest of us are entitled to move about and feel safe. So I think lawmakers are the ones that need to be sitting at this table with us, because we can talk about it until we're blue in the face, but until the laws are changed, we are all at the mercy of this broken system.
Thank you for that comment, Ms. Chandler. I hear so many important points, including the reiteration of the point Ms. Johnson was making about experiences of fear. And that is something that we are assessing through our community survey. So we are asking people about how safe they feel and, what kinds of experiences of fear they're experiencing. And I also hear your concern about having lawmakers involved in these conversations. And I agree that the more that we can broaden our coalition to include folks who have those kinds of impacts, the greater the power of this group will be. I know that, there's a lot of controversy around the policy of forcible hospitalization. And I think that it's important to keep in mind that, that's a little bit different from what we're here to discuss today, but I care deeply about the well-being of our community members, and I hear that you do as well.
Yep, thank you for that, Ms. Chandler. I want to bring us back to the list. We have Ms. Renee Mitchell. And then after that, we'll have Mr. Stuart Aronson.
Sorry, Claire, I think your audio was cutting out while you said that, but it was Miss
Renee Mitchell.
first.
Okay, I'm off camera. Sorry, I got in late, ladies. Okay, my name is Renee Mitchell. I'm the Executive Director of Breaking the Cycle Drop Corp, which is a safe haven for men's. I'm also the co-chair of the policy committee for the National Coalition of Homeless. I'm also a person with lived experience. And 2 decades ago, I was homeless with a drug problem, with my 1-year-old child and a mental health problem. And I became a pillar of the community. Okay, and I built a solid foundation for me and my child. And now I have a nonprofit called Breaking the Cycle Drop Corp. And my model is you got to break the cycle one homeless at a time. And what I'm incorporated on is ending homelessness through wraparound services. Okay, in New York City, you have a big problem in the New York City shelter system. Instead of, okay, any type of resources or services being done, it's 30 people in a room and everybody's waiting for a voucher with the one-size-fits-all approach. You can't keep putting Band-Aids and Band-Aids on things because it's going to be it's an open wound. It's going to eventually fester. They're warehousing people like cattle. Is profit over human lives. What I suggested to the mayor, okay, I done been in the meetings with the mayor, I done been in the meetings with the first Deputy Commissioner Molly Parks, okay, the New York City Controller, and a lot of people, is that if you put wraparound services on site in these shelters, like medical, mental health, substance abuse counseling, you are helping move these clients towards self-sufficiency so that they have options. Everybody, okay, even though they say housing first, everybody cannot be independently housed. And by having these wraparound services on site, it'll better assess what type of housing that they may need. If they have a serious medical problem, maybe they need adult home, assisted living, nursing home. If they have a drug problem, maybe they need a rehab before permanent housing. Maybe they need a TC. If they have a mental health problem, maybe they need to have a psychosocial, psych evaluation, Medicaid management, supportive housing, or MICA program. And until they do this in these facilities like the shelters, okay, like the jails, okay, it's going to continue to be a massive system failure. Now, under Kendra law, okay, if you're highly functioning, okay, then you just mainly need community-based services, okay, see a therapist, Medicaid management. But if you're not highly functioning and you have serious mental illness where you're pushing people off trains and you're stabbing people or you're busting people in the head, then it should be, okay, the renewal of opening up more psychiatric beds, psychiatric state hospitals for people, okay, to be stabilized that has these serious, violent mental health issues.
Thank you for that comment, Ms. Mitchell. I think that's such an important point. And that is the status quo, that is the current policy prior to this change from the Adams administration, was that when folks are clearly a threat to themselves or others, they are eligible for forcible hospitalization. So that is, I believe, the policy that we currently have. I hear you talking as well about the importance of co-locating services and creating cross-networked resources, which is part of the Harlem Strong initiative. And we're very proud that we are going to be able to address some of those needs for folks in the same location. I know we're tight on time. Claire, can you remind me, is it Mr. Aronson next?
Yes.
Yeah, just after 30 years of psych administration at Harlem Hospital, just the final word on the oversaturation. I think that refers to opioid and opioid addiction services concentrated in this area, where people from outer boroughs are coming to 125th Street with their opioid addiction So there's an issue of access for the broad subject of substance use disorders and substance use and misuse issues, in addition to some opioid addiction, but having all of those opioid and addiction services in that area is, I think, the oversaturation that is often referred to. I just wanted to get a sense. So Harlem Strong, the vision is that, for example, you would contemplate organizing a multi-service center, including mental health services, located at grant houses, for example. I mean, in NYCHA, within NYCHA, for example, you could foresee a multi-service center or a mental health clinic. Is that kind of, and that would be true in other settings, CEOs like you were talking about?
So there are actually many components to Harlem Strong. One is a coalition, which is a network of all different types of organizations coming together to plan around how they might integrate aspects of mental health care into their workflow, or to share resources, become a referral source, share information about activities related to mental health and social services and other, related areas that can support the community. So that's one component of it. The second is building capacity for mental health task sharing. And what that means is training folks on how to screen, how to provide psychoeducation, how to make a referral, and how to engage in some very brief stress management counseling, where we would train navigators if your site has navigators. If they don't, they can, participate in as much or as little as necessary for your organization, or feasible for your organization. And so our trainings will be made available to the network of organizations. That's part of it. Then for the study itself, we are implementing this model in housing, and that is going to primarily be HCCI. So it's affordable housing, along with potentially Hope Community, another organization, and then primary care sites that are affiliated with Healthfirst. And so the navigators will be housed within those organizations, and the full model will be implemented there. And they will provide support, through the network, essentially, for other types of services. And so, there'll be additional resources for those sites, but then for everyone else, we will make whatever resources that are feasible for us to offer to the rest of the network.
Be a great gift for the hospital.
Yeah, and including the hospital. If you want to send folks to our trainings, we're happy to receive them and support them. And if the hospital is interested in engaging in any of the services, we would love that. We think that would be great. And we want the hospital to also be a referral source as well. And the coalition is supposed to support the planning of some of this, so that it can be integrated in ways that make sense for different organizations, because we know that there are unique needs for each organization, and there needs to be some process of figuring things out. It cannot be a one size fit all, which is why we're providing like a suite of opportunities, essentially, whether they be training opportunities or connection opportunities, or opportunities that's made available to everybody. Thank you for those questions. And I think, who do we have next, Claire?
I guess we have time for one final question from Gordon Mohammed.
Oh, I'm sorry. I think I pressed it by mistake, but it's okay. But I was just just thinking too, maybe we can since the coalition, everybody's all part of the whole coalition team, maybe we could start putting together maybe crisis intervention specialists or specialized outreach workers to all work together, do the outreach surveillances at night and the day, and give the feedback information to real time, where we can start targeting a lot of the problems that's going on and just fixing it. I realize that sometimes when I'm up there, we're doing my our outreach and engagements. I'm meeting people who's not even from Harlem. I'm meeting a lot of clients who want to come to Harlem and get a quick fix. you know, and now they're bedded down on the sidewalks and everything. And it's hard, it's really hard to say, you know what, they got to go to the hospitals, because that sometimes when you're under the influence of certain things, they won't do as much treatment because we don't know what reaction they're going to get. They're going to become violent. That's one thing. And the other thing too, most of the clients who's out there trying to get a good quick fix and everything, a lot of things that go on are from Ward's Island. You speak to a lot of the clients, they say, well, listen, I hate Ward's Island because one, I'm being treated as Rikers Island or as an inmate. They're not getting the right case management work. So it's a lot of things that got to be touched on. But I think if we work as a team and a unit and, you know, break it down, everybody come together, I mean, we could fix a problem. It's going to take time, but it's going to work out in the long run.
Thank you so much for your optimism, Mr. Mohammed. We hope to take that spirit with us as we end this meeting. We do hope to work together and address some of the community's mental health needs and also provide additional support and resources to everyone. Dr. No, you want to?
Yeah, I wanted just to kind of say a few things about the coalition. Just, you know, I know that there was a question about how do you get involved. And so, you know, we will be enrolling sites and providers into our coalition in January. And so, you know, we would love to take all of your names and, you know, send you the invitation for those meetings so you could hear more about what we're going to be offering and what the requirements might be. There'll be, you know, this is a research project. So what we want to do is assess the impact of this and determine whether, you know, being involved in a coalition, engaging in mental health task sharing training will in fact change services and, you know, change the impact on consumers. And so, you know, that will be part of the work that we do in the coalition. And so we will definitely be reaching back out to you all. I think we'll have everybody's email address from this list. So those invitations will be, will be sent to you all. And then in addition to that, I just wanted to also say that, you know, if you have any specific interests, any needs, please feel free to reach out to us. You know, we can address them separately. And then thirdly, I know that there were many suggestions about having breakdowns of information about CBOs and resources. And one of the things we want to do in the coalition is to gather information from you all so that the information we have about your organization is accurate, so that the directory and resources we put out there are also reflective of what is current, because there have been lots of changes. And so we'll also be reaching out to you about that as well. And thank you all for joining us today. This was such a great discussion. We have so many things to think about as we plan for the launch of the coalition, and we look forward to working more closely with you and getting to know you all. Thank you.
Thank you so much.
Thank you.